Hello and welcome to Mission Cure's webinar on understanding type 3C diabetes. My name is Megan Golden, and I am one of the co-founders of Mission Cure and now the CEO. I'm here with my colleagues, Dr. Lola Rahib, Shruti Mirashankar, Daniel Morgan, Isabel Aguirre, and Olivia Zaiden. And our board chair, co-founder Linda Martin, may be joining us as well from afar. I welcome you to our webinar for pancreatitis patients and families and others affected by type 3C diabetes. And I also welcome our community of clinicians and scientists who are joining us today. We have 220 people registered for this webinar, which is very exciting. So a little bit about Mission Cure. Next slide, please. I co-founded Mission Cure in 2017 after my brother Eric was diagnosed with chronic pancreatitis. And Linda Martin, whose daughter Amy was also suffering from chronic pancreatitis, is my co-founder, board chair, and just overall partner in crime. When we learned that there were no approved treatments to stop or reverse the disease, that was just not okay. We started this nonprofit to find effective therapies and improve patients' lives. And we've been working toward our mission for 6 years now, and we are making progress. Between last year and this year, there are 3 clinical trials testing what would be the first ever treatment for chronic pancreatitis. And you can find out more about the clinical trials that you might be able to enroll in if you have pancreatitis on our website. But right now there's one clinical trial in Southern California, and there will soon be trials in South Carolina involving stem cells and Alabama, and more are coming after that. We are committed to offering actionable information to the pancreatitis community, and this webinar is part of our patient education program, which is supported by AbbVie, and we thank AbbVie for their support. So I want to introduce our program associate, Isabel Aguirre, who will go over the agenda for the day and get us started. Isabel.
Thank you, Megan. Our webinar agenda is outlined on this slide. Today, we will explore the connection between pancreatitis and type 3C diabetes. From our pancreatitis community, we know that being diagnosed with pancreatitis brings a host of other worries and complications patients might need to face and prepare for. Some of these complications deserve a bright shining light on their own because of their impact on a patient's overall health and quality of life. One of these known risks is how pancreatitis can lead to type 3C diabetes. Diabetes is often called the silent killer because it quietly impacts multiple organs when left unchecked and unmanaged. Today, we're focusing on type 3C diabetes, less known than its counterparts, type 1 and type 2. Given its link to pancreatitis, we want to equip you with the latest insights on type 3C diabetes. We aim to empower you to recognize and tackle this silent threat, helping you take control of your health and well-being. Before we start, please know that this webinar will be recorded and posted on Mission Cure's website. You have joined in listen-only mode, meaning we can't hear you. If you have any questions, there's a Q&A option on your toolbar at the bottom of your screen. Please type them into the box. At the end of this webinar, our speakers will answer them. I welcome our first panelist, Dr. Melena Bellin, an endocrinologist, professor, and physician scientist at the University of Minnesota with over 20 years of patient care experience. Dr. Bellin's research specializes in diabetes and total pancreatectomy and islet autotransplantation. She is known for offering compassionate care to pediatric and adult patients with type 3C diabetes and acute and chronic pancreatitis, TPIAT, type 1 diabetes, and other endocrine conditions. She will now talk to us about the connection between pancreatitis and diabetes and cover symptoms, diagnosis, and treatment options. Over to you, Dr. Bellin.
All right, thank you. Thank you very much to the Mission Cure team for inviting me today. And I've had the honor of working with Mission Cure, I think, since nearly the beginning. And they are really an outstanding organization and really important in the field. And thank you to the audience. I recognize a few names, which is wonderful to see all of you virtually here. So obviously, I'm going to be talking about diabetes in the setting of pancreatitis today. And I know many of you are patients who have pancreatitis, or maybe you have a family member with pancreatitis, or maybe you care for people with pancreatitis. But I want to start very basic and not assume any knowledge coming in, and just talk a little bit about what the pancreas is. So when we talk about the pancreas, 98% of that pancreas is the exocrine tissue. And so when I say exocrine tissue, I mean the ducts and the acinar cells. That's the part of the pancreas that secretes the digestive juices into the digestive tract to digest your food. And it is the part of the pancreas that is affected when someone has chronic pancreatitis or acute pancreatitis. So this is the portion that's getting inflamed and gets scarred. But the other part of the pancreas, the part that's near and dear to me as a diabetologist, is the endocrine tissue. So the endocrine portion of the pancreas, that's made up of the islets. And so you'll hear the term islets or islet cells, and note that it's spelled ISLETS, but it is pronounced like islet, like eyelid, islets. And each islet is a cluster of cells. So within those clusters of cells, there's various cell types that make hormones that get secreted into the bloodstream to control or regulate your blood sugar. And the one that we talk about the most are the beta cells. The beta cells are the cells of those islets that secrete the insulin. And people who develop diabetes are often deficient in insulin or not making enough insulin. So although this is not a part of the pancreas that is causing pancreatitis, it's a part that gets damaged as people have pancreatitis. Go on to the next slide here. So when someone has pancreatitis, oftentimes the symptom that is the presenting symptom is obviously pain and all of the things that come with pain. But as the disease progresses lifelong, there's inflammation and scarring in the pancreas that damage both that exocrine portion and the islet portion of the pancreas. And so the risk of getting exocrine insufficiency or malabsorption and the risk of getting diabetes goes up with time. If we look at sort of cohorts, particularly in the US population, in what we would call a cross-sectional, so, looking at people at any point in time, about 6 to 8% of children with recurrent acute or chronic pancreatitis will have diabetes, and about 40% of adults with chronic pancreatitis will have diabetes. You can go on to the next slide. So oftentimes when someone has pancreatitis and diabetes, the question they might hear from other people is, well, what type of diabetes do you have? So I want to start just talking a little bit about terminology, and I'm not going to talk about type 1 or type 2 diabetes in this talk, but just for reference, type 1 diabetes is an autoimmune form of diabetes where people lose all of their beta cells. It usually occurs in children or young adults, but it can happen at any age. And type 2 diabetes is the type of diabetes that people oftentimes associate with obesity. Not everyone who gets type 2 diabetes is overweight or obese, but many people are, and they have resistance to insulin, meaning their body doesn't respond as well as to the insulin they make. And their pancreas doesn't make enough insulin to overcome that insulin resistance, and therefore they get diabetes. You also hear about gestational diabetes, but then there's all these other forms of diabetes that you hear less about that are caused by other things going on, like pancreatitis or cystic fibrosis. And a lot of times this sort of category of diabetes that occurs because of exocrine disease is grouped into type 3C diabetes. Where type 3C diabetes came from, it's not an endorsed term by any medical society. It's used often. It actually came out of the American Diabetes Association, not because the ADA endorsed this terminology, but because they had a table where item 1 was type 1, item 2 was type 2, and then item 3 was other forms of diabetes, and letter C was diabetes from exocrine pancreas disease. So hence type 3C diabetes. The other terms you'll hear for this is pancreatogenic diabetes, pancreatic diabetes, post-pancreatitis diabetes. These are all really referring to basically the same thing. Unfortunately, this lack of uniform terminology can create a lot of confusion. And so you might go into your doctor and say, I have type 3C diabetes. And they say, what are you talking about? There's no type 3C diabetes. And so this is where the nature of that confusion comes from, is just the lack of agreed upon terminology. I will note at the bottom of the slide is the reference to something called type 3 diabetes. It's also not a term used in the medical community much, but if you search on Google for type 3 diabetes instead of type 3C diabetes, you might see this come up as a term that's used with diabetes with Alzheimer's disease. So don't be confused by that. So type 3C diabetes is mainly the term I'll use today because I think it's simple and easy to say, and it's well recognized by the patient community. Go on to the next slide. Unfortunately, type 3C diabetes, you don't hear much about, and it doesn't always get properly diagnosed. And there's a number of reasons why I think that occurs. There's simply a challenge in like the terminology and making that diagnosis. When you don't have good, consistent terminology, it actually makes it harder to make a proper diagnosis. And in the medical community, when we're making prescriptions or billing for visits, we use these ICD-10 codes, right? These number codes that refer to specific diagnoses. And there is no specific ICD-10 code for type 3C diabetes. And in fact, if you want to get something through insurance, a lot of times you have to code it as type 1 or type 2 diabetes because that's the only thing on the checklist for prior authorization. So the coding and the terminology is confusing. There are people who have chronic pancreatitis who don't get properly diagnosed with chronic pancreatitis. So when they show up with diabetes, it might be assumed to be type 2. It's just simply under-recognized. Even in people who have known pancreatitis, if you show up in a primary care clinic with diabetes, you're likely to get diagnosed as type 2 or sometimes type 1. So it's just not even really recognized well enough as a specific form of diabetes. And to be honest, there's overlaps in features between different types of diabetes. So it's not there's not three kind of perfect boxes for type 1, type 2, and type 3C diabetes. So for example, people who are obese or have a strong family history of diabetes, which are things we think of with type 2 diabetes, are also more likely to have type 3C diabetes. So there's some overlap in what we would call the phenotypes or how people present. You can go on to the next slide. So one of the questions that comes up is how common is type 3C diabetes? And in fact, you could ask this question two ways, and these are this slide and the next slide. The first slide here is how common is type 3C diabetes versus other forms of diabetes? So if you take people with diabetes as the diagnosis, how often do they have type 3C diabetes? And the other way to ask this is if you have chronic pancreatitis, how likely are you to have type 3C diabetes? So taking this first question here, in people with diabetes, how often is this type 3C diabetes? How much do we see this? So the first question here, probably one of the best pieces of data to look at this was a study that came out of the United Kingdom, where they actually looked at 31,000 people who had a new diagnosis of diabetes. These were all adults, and looked at, was this type 1? Was this type 2, or was this new diabetes and someone had acute or chronic pancreatitis, or say type 3C diabetes? And in fact, in that study, type 3C diabetes was more common in adults than type 1. So for an adult newly presenting with diabetes, it may be more common to have type 3C diabetes than it is even to have type 1 diabetes. So this is less common than type 2, but certainly not rare. It's at least as common as type 1. The other study that gets cited a lot that has looked at this is a cohort that came out of Germany. And this is a tertiary care center, so sees a lot of complex referral patients, where they looked at everyone who had come in who had diabetes and sort of reclassified them. No matter what form of diabetes they were diagnosed with, they took a new, fresh look at it. And if they had pancreatitis, for example, they reclassified them as type 3C diabetes. So looking at that, about 9% of patients had type 3C diabetes. You can have type 3C diabetes because you have other forms of exocrine disease, not just pancreatitis. So people with cystic fibrosis or pancreatic cancer kind of fall under this umbrella as well. But in fact, when they looked at sort of the subdivision of that, which is the figure on the right here, these 9% of folks who had type 3C diabetes, 79% of them had chronic pancreatitis. So you could say in this study about 1 in 10 people with diabetes actually had type 3C diabetes. Now I will say that that's a specialty care center. So you're more likely to see these patients at specialty care centers because they have so many complex medical issues that's where they're likely to receive their care. So that might be a little bit misleading. But I think the take home point is it's common. It's not a rare form of diabetes. Even though we know a ton about type 1 diabetes, we just don't know that much about type 3C diabetes, which is probably equally as common. Next slide, please. So I'm going to ask this the other way now, which is how common is diabetes if you have chronic pancreatitis? And I sort of alluded to this at the beginning. If you looked at just kind of a point prevalence in the population, about 1/3 to 40% of folks with chronic pancreatitis will have type 3C diabetes, but this risk goes up through the lifespan. Right. So it kind of depends on who you're looking at, how long they've had diabetes, or how long they've had pancreatitis, sorry, what type of pancreatitis they have, what kind of treatments they've had. If they've had surgery or resection, they're more likely to have diabetes. But the lifetime risk is anywhere up to 75% of folks in their lifetime with chronic pancreatitis may develop type 3C diabetes. And the graphic here is actually one for patients specifically who have hereditary pancreatitis. There were a couple cohorts of patients in Europe that were followed with hereditary forms of pancreatitis, mostly PRSS1, although not entirely PRSS1. And that graphic there shows the age of the patient versus the percent of patients at that age who had diabetes. And you can see it is relatively uncommon in childhood, but as people get up to be 60 or 70 or 80 years of age, this becomes quite frequent that they develop diabetes. So the longer the process goes on, that risk goes up. Next slide. And I will turn it over to the Mission Cure team because they're going to take a brief poll.
Yes, and now it's time for a quick poll. Help us understand your experience with pancreatitis and diabetes by voting on the query that will show up on your screens in a few seconds. We have 2 questions for all of our attendees about diagnosis and being informed about the risk of type 3C diabetes. Please choose the option that's most applicable to you and make sure you answer both questions and submit them. And you should see the poll on your screens now. Make sure you get all of your votes in the next 10 seconds, please. Great. Go ahead and submit your answers now. And now we will share the results of the poll. Great, thank you so much everyone for answering. It looks like we have a wide range of answers and a good mix here today. So thank you everyone for answering our poll. Thank you again for taking time to share your experience with us. We hope that the information we share today helps you on your journey. And a quick note, please type any questions into the Q&A box on your screen and we will answer them at the end of the webinar. Dr. Bellin, back to you.
All right, thank you. Yeah, it looks like we have an excellent mix of individuals attending today. So you can go on then to the next slide here. So we're going to get into a little bit now about why we think people with pancreatitis get diabetes, some of which we know and some of which we don't. That's why it's still being researched, and the treatments. So these next few slides here go through a number of things that we think contribute to people with pancreatitis and diabetes. So the first one, and probably the most well recognized and longest understood one, is that many people who have pancreatitis, because of their pancreatitis, make less insulin. And we know this for a few different reasons. So we know this because we can actually measure insulin, or C-peptide, which is another insulin marker, in people who have pancreatitis. And if they have diabetes in particular, we'll see reduced insulin secretion for many of these individuals, especially with more advanced chronic pancreatitis. And people have actually looked at pathology, so looked at pancreases that were either resected or in autopsy studies of people who had died and had chronic pancreatitis. This is specifically chronic pancreatitis, and this is the figure at the right, looking at islet area or beta cell area in this case. And people who have diabetes with chronic pancreatitis have fewer islet cells or beta cells than those people who don't have diabetes. So we understand that some of this is driven by inability to secrete enough insulin. And that's classically thought to be because the fibrosis, the scar tissue, damages the islets as it's scarring the digestive pancreas, and or some of the inflammation that's in the pancreas with pancreatitis causes the islet cells to not work as well. That part may or may not be reversible, the inflammation part. And then, of course, for people who have surgery, right? So there are some people who have a partial pancreatectomy, a total pancreatectomy, or a total pancreatectomy with their islets transplanted. But all of these result in at least some loss of the pancreatic islets, so we have some level of insulin deficiency. So for many or most people with pancreatitis, there is a component of insulin deficiency, and that might be mild to severe insulin deficiency. Next slide. So the second reason that we understand affects at least some people, and I'm not sure this affects everyone, but some people seem to be less sensitive to the insulin that their body makes. So something we call insulin resistance. And why do we think that? This is probably a little less well studied than the insulin deficiency. So for one thing, we know that people who have chronic pancreatitis, who are overweight or obese, and this is the table on the right, have a 1.5 to almost 3 times increased risk of developing diabetes. So what we think happens there is if you're not able to make enough insulin because your pancreas is damaged, and you're also obese, and associated with that, your body needs more insulin. It's insulin resistant, so your body needs more insulin to normalize blood sugars. Then you get kind of tipped over the balance, sort of tipped over the edge into having diabetes. So that's one factor. There's some other more detailed studies that have been done that you can actually measure insulin sensitivity. They've been done in very small numbers of patients, which is why I think they don't necessarily apply to everyone, but there are some studies that have looked at people using very sophisticated methods and showed insulin resistance. So there may be some component of the body not responding as well to the insulin we make. Next slide, please. And we think that there might be other hormones contributing. So this is probably the least well-known or well-studied of all of the potential mechanisms. So there's 2 hormones in particular that come up here. There's one called pancreatic polypeptide. It's made by your islets. And so when someone has chronic pancreatitis in particular and scarring of the islets, they make less pancreatic polypeptide. What we do think is that this might be a marker. It's not used clinically yet, but might be a marker that could distinguish someone who has type 3C diabetes from someone who has type 2 diabetes. So trying to tell those 2 apart. It's a little bit less certain, I think a little more controversial as to whether there's an actual role of pancreatic polypeptide in contributing to the development of diabetes. And the same for these gut hormones called incretins. So GLP-1 or GIP. A lot of people have heard of these now because GLP-1 are a set of drugs that are available like Ozempic, but these are actually hormones that your gut makes normally, GLP-1 and GIP, that help the islets function. And so some people think with chronic pancreatitis and you get malabsorption, maybe those hormones that help the islets function don't work as well. But there's the evidence on that is a little bit mixed. They probably don't work as well, but whether or not that contributes to the diabetes is the part that's a little less clear. Next one. So why is this all important? Like, why do we even care why pancreatitis leads to diabetes, or how that happens if we know it happens. Well, it affects our treatments. And so this is an example of this. This figure here is a graphic that came out of this population study that I referred to earlier from the United Kingdom, where they looked at 31,000 adults who got newly diagnosed with diabetes and classified them as type 2 pancreatitis related or type 1. Type 1's not on here because this is a graph of who needs insulin. So this y-axis, or the axis on the side, is freedom from insulin, and everyone with type 1 diabetes needed insulin. But what I'm showing you here is that the people who had type 2 diabetes mostly didn't need insulin over a 5 to 6 year period. Most of them were treated with non-insulin medications. But the group with acute pancreatitis and chronic pancreatitis needed insulin much more frequently and earlier in the course of their diabetes to replace that insulin deficiency. So this is just an example of, what we know about the mechanisms or the causes helps us tailor the treatments and guide treatments. Next section, please. So the very first thing, if we're going to treat diabetes, is we need to be able to diagnose it, right? So we need to be able to screen and diagnose diabetes. And actually, the diagnosing diabetes part is much simpler than figuring out type 3C versus type 2 versus type 1. Because essentially all diabetes is diagnosed using the same diagnostic tests, and high blood sugar can have the same symptoms in everyone, whether or not they have type 1 or type 2 or type 3C diabetes. So usually people get diagnosed with diabetes without realizing they have symptoms, because those symptoms are either absent or so subtle. But people might have symptoms of feeling really thirsty or urinating frequently. Those would be the most common symptoms of diabetes. Or they might be fatigued or losing weight or get blurry vision. But we do recommend, and I'll get to this in the next slide, screening everyone who has pancreatitis for diabetes, because a lot of times you don't have any symptoms early in the course. And the tests that are used for diagnosis include a fasting glucose or fasting blood sugar, a hemoglobin A1C level, which is a marker of the average amount of sugar in your bloodstream over the previous 3 months. And then once in a while, oral glucose tolerance test, where someone drinks a really sugary beverage and you look at a glucose at 2 hours. So memorizing the cutoffs for these diagnoses is not important, but you can use any of these tests of glucose or A1C to make the diagnosis of diabetes. Next slide here. So we do recommend screening. Until recently, there weren't really any endorsed screening guidelines, and I'm happy to say that in 2024, the American Diabetes Association, for the very first time, recommended providers actually screen people who have pancreatitis for diabetes. So this is actually an official guideline that providers actually look to this source of information for the ADA to see who to screen. And so what these guidelines say is that people both with acute and chronic pancreatitis should be screened for diabetes. If you have acute pancreatitis and that's a new diagnosis, you should get screened within 3 to 6 months after that episode, and then annually. And if you have chronic pancreatitis, you should be screened at diagnosis and continue to be screened annually. And the key screening tests here are doing the fasting glucose and the A1C level, because they're very easy to get in any lab. And if someone has a borderline test or there's a concern, you might add that oral glucose tolerance test, which is also not difficult. It just takes 2 hours to do, so it's a little bit more involved. People should be screened. And obviously, if diabetes is diagnosed, then we need to get to what do we want to do to treat that diabetes. And here's what I'll say, that I'm going to tell you what we usually do in clinical practice and my personal opinion on treating these, but we actually have no randomized trials to guide this yet. And so this is not like type 1 and type 2, where there's been actual clinical trials to approve medications for treatment. We're simply taking the medicines that have been studied for type 1 and type 2 and repurposing them to treat type 3C diabetes. So by far the most common drugs that are used are metformin, which is an oral medication or a pill, and insulin, which is injected or given by a pump. The metformin, what it does is it helps your body respond better to insulin, improves insulin sensitivity, and particular insulin sensitivity in the liver. So our liver does actually a lot of the glucose regulation for our body. And then the insulin obviously just replaces the insulin your pancreas should be making. So it replaces the insulin deficiency. So there's many other drugs that are approved for type 2 diabetes that we either don't use or aren't sure about what to do with in people with pancreatitis. So the ones that do sometimes get used, but I would say, in my personal opinion, are best to avoid are the ones that are in kind of this GLP-1 category. So there's these ones called GLP-1 agonists on the news a lot right now because they're weight loss drugs, very popular weight loss drugs, Ozempic, Wegovy, Victoza. These give very high levels of a pharmacologic form of GLP-1. So they stimulate that GLP-1 pathway and they can improve insulin secretion. They might actually help with diabetes, but they may have a risk of pancreatitis, which is why I do not like to use these in people with pancreatitis. I just think that there is a good risk about that, a good risk with that we can't justify the use if we can treat with other medications, which we can. And then the other is the DPP-4 inhibitors. So these I think get a little bit less often talked about, but they're simple because they're pill form. So things like Januvia, sitagliptin, they also work by that GLP-1 pathway and might have a pancreatitis risk. So those are the ones I stay away from. The ones that aren't, I think, used very often and just don't have evidence right now, but might in the future, are we called it the TZD category, but really the only one in the US is called Actos, that improves insulin sensitivity. A whole newer class of drugs called SGLT2 inhibitors that actually make you sort of pee out glucose or sugar in your urine and thereby reduce blood sugar. Invokana, Farxiga are a couple examples there. And then these really old classes of medications called sulfonylureas that help with insulin secretion. Those are the ones that we're not really certain what their role is. Next slide. So why are insulin and metformin really the treatments of choice and well used? Well, insulin treats the insulin deficiency, so it really targets the primary defect, at least for most people with chronic pancreatitis. And for people who have had, say, a TPIT procedure, we think this reduces sort of putting metabolic stress on the islets. So this is a really important treatment choice, and it probably is the best choice if you have someone who has very severe advanced chronic pancreatitis, a lot of calcifications in the pancreatitis, very thin people, documented low C-peptide or insulin levels. The oral medication metformin might be considered before starting insulin, sort of as a first line in people who are overweight, who have high C-peptide or insulin levels, kind of indicating insulin resistance or a strong family history of type 2 diabetes. There also might be, although the evidence here is a little bit mixed and not clear, there might be a theoretic role of metformin in lowering the risk of pancreatic cancer. So that's had some appeal, especially in the gastroenterology community, for either using metformin as the first line alone or using metformin with insulin. It is a very safe and inexpensive drug, so it also has that appeal as well. Next slide. I'm a pediatric endocrinologist by training, and I do a lot of treatment with diabetes technologies. So I think there's a huge role here for people who have more severe insulin deficiency of diabetes technologies. And so continuous glucose monitors are really gaining traction as the way to monitor blood glucose, largely supplementing or sometimes replacing the finger poke method. The kind of the classic method of monitoring blood sugars is to, of course, poke your finger and use a meter. And these CGM or continuous glucose monitoring devices can be put on the back of the arm or stomach or butt, depending on the device, and can monitor the sugar level continuously. It's not in the bloodstream, but it's pretty close to the blood sugar and the reporting it gives you. And then you can use pumps, insulin pumps, to deliver insulin therapy. So just a different way to deliver insulin. What we do know about people with pancreatitis and diabetes is that they're more complicated than your sort of routine type 1 or type 2 patient, and I think best cared for in the perspective of a multidisciplinary team. So we have all these factors in people with pancreatitis, with malabsorption potentially, deficiency, glucagon deficiency, because they've also damaged their alpha cells. So glucagon is a hormone that raises blood sugar if you're getting low. Fluctuating states of illness, which affects your insulin sensitivity and what you can eat and drink, and physical activity changes. All of these can make for more variability in blood sugar and complicate diabetes management. So working with a endocrinologist, a gastroenterologist, a diabetes educator, a dietitian, in addition to your primary care provider, is really important for these patients. Exocrine pancreatic insufficiency is more common for people who have type 3C diabetes than people without type 3C diabetes. So we should always be screening for exocrine insufficiency regularly as well, and making sure it's adequately treated when present, and especially for people on insulin. You can't get good control with insulin therapy if you're having a lot of irregular absorption. So this is particularly important on insulin therapy. And, you know, having this multidisciplinary team and an expert endocrinologist helps when it comes to the prescription side of things, because this lack of diagnostic coding, no ICD-10 code, no specific FDA-approved medications for type 3C diabetes can really complicate getting insurance approval. So those are all some of the known considerations in treating other than medication selection. Next slide, please. So I just want to highlight that there's some really great research going on still in this area. And I think if I came back 5 years from now, we'd know a lot more about some of these treatment questions than we do now. And that's because the National Institute of Health has funded a number of very large clinical studies in this area through the chronic pancreatitis diabetes pancreatic cancer consortium, or the CPDPC, and the type 1 diabetes acute pancreatitis consortium. So just want to acknowledge the role of NIH in supporting this work, and more to come. And in conclusion here, so I think as we heard, the diabetes risk is increased in people with acute and chronic pancreatitis. So please, if you have pancreatitis or know someone with pancreatitis and have not been diagnosed with diabetes, getting screened annually, at least with a fasting glucose and A1C, is important. The mechanisms driving diabetes may differ between different individuals, but probably include insulin deficiency, with or without some component of insulin resistance, and maybe some other hormone components that we don't fully understand yet. In chronic pancreatitis, factors like obesity and family history can increase your risk, as can some of the factors of the disease, like whether you've had surgery or if you have a lot of calcifications or scarring in your pancreas. And although we lack our definitive treatment studies, common accepted treatments are insulin and metformin. Thank you. And I will, I'll wrap it up, and I will send it back to the Mission Cure team for the next step. I will say we'll have more Q&A here at the end. And of course, I'm always happy to be contacted directly as well if there are questions that weren't answered by this session. I know it was a lot to get through in a short time. And of course, I do this in the context of having a really wonderful team and really wonderful sources of funding and other supporters who I want to acknowledge here. All right, thank you.
Thank you, Dr. Bellin, for sharing this vital information with our community. Pancreatitis patients can now talk to their doctors about this risk, get screened, and catching the issues early on. Quick note to our audience. Again, if you have any questions for Dr. Bellin, please share them in the Q&A box and we'll address them shortly. And let me welcome our second panelist, Shruti Meera Shankar, our patient voice for this webinar. You may know Shruti from our previous webinars as the host leading our patient education program. But today she's participating as a patient speaker because of today's topic and how it has impacted her journey. Thank you for your willingness to share your experiences with our community, Shruti.
Thank you, Isabel. Hello, everyone. I hope you can hear me. Today, I'd like to share my lived experience with you as a chronic pancreatitis patient myself, who also has a diagnosis of type 3C diabetes and has lived with this complication for nearly 8 years now. My journey with pancreatitis began over 10 years ago in 2013, when I started experiencing excruciating, unexplained abdominal pain. And I was officially diagnosed with acute pancreatitis over a year later. In the middle of understanding pancreatitis, all the ups and downs associated with the hospitalizations, trying to rule out the possible causes, diabetes being a risk factor kind of got lost in the mix. I was not informed about this type of diabetes and carrying a higher risk of developing it because of pancreatitis itself. During one of my hospitalizations for acute episodes, while running a routine blood panel to find out how I was doing, a random blood glucose test was done, and we found it to be really high. This happened consistently for the next couple of days. This does not make any sense because I was not consuming any foods, solids, or liquids, and I was on IV fluids, saline, with no sugars in them. Of course, before this particular hospitalization, I'd already had about 5 to 6 acute pancreatitis attacks, and they were already in my bag. A HbA1c was added to the list of blood tests, and it showed elevated levels, but not enough to be diagnosed with diabetes. I was given oral medicine to help control the high blood glucose level, but it did not bring the levels down. And I was given low doses of insulin while I was still hospitalized to help control my blood glucose. I felt a little better in the next couple of days and was ready to consume liquids and semi-solid foods. And by now, my sugar levels had returned to normal with insulin. Upon discharge, I was asked to keep a check on my sugar levels and consult a diabetic specialist. At this stage, I was informed that pancreatitis can also lead to diabetes. Plus, I also had a familial risk of type 2 diabetes, but no family history of pancreatitis. After discharge, I went to doctors who specialize in diabetes treatment to help manage my blood glucose levels and take care of this new diabetes. No type 3C was mentioned, and the differences between this kind of diabetes and other types were not highlighted. It was diabetes. And as a result, I was seen and treated like all other diabetes patients. I was initially asked to be on low insulin doses since I was responding to those, and oral medications were added to the list to help manage diabetes better. Over the next year, my frequency of pancreatitis attacks increased rapidly. It came to a point where I went from experiencing an acute episode every 5 to 6 months in the previous years to having one every 2 to 3 weeks, leaving no room for recovery. A few of these acute episodes came right after I started a new regimen of diabetic pills, including the DPP-4s we heard about earlier. I started literally staring at my results and hospitalizations and bills, not knowing what to do with them. At each doctor visit, I would talk about my pancreatitis history, share my food, medication, and symptoms diary, and talk about some attacks that occurred just after the medications were changed. I went through 3 diabetes specialists and stayed with them for 3 to 6 months at least to work with them and see how my body would respond to medications they wanted me to try. Every time I raised concerns about oral medications, the explanations I heard varied from, this medicine is not linked to pancreatitis, so it's not the reason. Or, your attacks must be from something else. Or, this disease is just the disease trajectory, and the pain might not be related to pancreatitis. By now, I was a veteran in recognizing acute pancreatitis pain, so this, again, did not make sense. I also heard the goal is to reduce your external insulin need and get better with diabetes management with pills and other lifestyle factors. So let's wait and see. I did not have an expert who took notice of my symptoms, including my croaking pancreas. I prioritized resting and recovery of it and understood the challenges of using oral medications in some pancreatitis patients. Doctors did not consider that the risk of pancreatitis attacks can increase even with certain medications, or look into the lack of research surrounding this. This whole process was so frustrating, confusing, disheartening, and very, very painful. I wish no one has to go through this struggle and has to fend for themselves each time they go to a doctor and ask for help. And the availability of a well-informed and experienced multi-care team, or even a suggestion to look for one, could have made such a difference to me when I was dealing with all of this. Having coordinated support and expertise could have helped me rest and perhaps even save the functioning of my pancreas without it being subjected to repeated onslaughts. It came to a point where I just gave up on oral pills and just stuck with insulin. and learned to manage it better for the next 2 to 3 years. Only after I received a diagnosis of chronic pancreatitis, and when I could find experts who were willing to work with me and do the background research when I expressed concerns, did I experiment again with oral medication, including SGLT2s. I found them unsuitable because it could lead to fungal infections, another complication I honestly had no strength to deal with anymore. And I still chose not to give up, and I did my own research and kept searching and found an expert endocrinologist who's very familiar with pancreatogenic diabetes. In the last couple of years, we've settled on a combination of insulin and metformin by testing out metformin doses using a step-up approach. We work with data from my continuous glucose monitoring devices and my symptoms to find regimens that work. We focus on dietary changes and physical activity alongside the medications I take. This has worked well. I still have challenges with it to this day, but I can rely on my current doctors to understand what I'm dealing with and tailor my treatment options by using a risk versus benefit approach. And that's made a huge difference to me. To all pancreatitis patients and caregivers, I urge you, get screened. Find experts who are willing to work with you and have the disease expertise. Keep a tracker of your symptoms, your concerns, day-to-day habits, any changes you notice, and work towards building a multi-care team. This team needs to understand the connection between your pancreatitis-related symptom, your dietary needs and restrictions, and your ability to stay active, and other influencing factors that Dr. Bellin highlighted. Stay proactive in managing your complications, including taking your medications in a timely manner, and attend to all of your health needs, including your mental health. As fellow pancreatitis patients and their caregivers here will know, we need and deserve all the expert help and compassionate support we can get. Today, I want to thank you all for being here and for listening to my experience with type 3C diabetes. And a special thanks to my team members at Mission Cure for hosting our webinar so I could participate as a patient speaker today. Thank you. It's now time for our Q&A session. I know we've got a lot of questions that have come in, and I'll pass it over to Megan so she can lead us into the session and get to those queries. Over to you, Megan.
Thank you. And Shruti, thank you so much for sharing your personal experience. I know that wasn't an easy thing to do. So we really appreciate it. And thank you so much to Dr. Bellin for being our main speaker here today. We have a lot of questions, so I think maybe I'll ask a couple of them, and then you can take a couple at a time. One of these you answered is type 3C diabetes inevitable for people who have chronic pancreatitis? And is there anything a chronic pancreatitis patient can do to prevent or reduce the risk of diabetes?
Yes, both very good questions. So I wouldn't say inevitable. I would say that the risk goes up, right, as you progress in your disease, but not everyone with chronic pancreatitis will get diabetes in their lifespan. So no, not everyone is going to be affected. And in terms of prevention, this is kind of the holy grail, right, of some of these like studies that I referred to with the NIH that follow people with pancreatitis, because one of the things is, okay, how do we flag those people who are going to develop it and understand the mechanism so we can intervene, ideally not just treat diabetes, but intervene before it starts. So I don't have anything data driven on this, except to say that since we know that obesity can increase your risk, right, of getting diabetes, even with pancreatitis, I think that things that you can do that would, maintain a healthy body weight, if you're healthy enough to be able to be physically active, I think these type of things are probably going to have some impact on your diabetes risk. But unfortunately, beyond that, we don't have a sort of a therapy or anything to prevent progression to diabetes. That's more of a goal of ours of research than something we know now.
And does taking pancreatic enzymes help or hurt short-term and long-term?
Well, they don't hurt. You know, you're going to be better off if your body is nutritionally getting what it needs, for many reasons. Do know that if you take pancreatic enzymes and you absorb better, you might see that reflected in your blood sugars because you're restoring normal absorption. But I wouldn't interpret that as a bad thing, just the same way we wouldn't want to treat diabetes by making someone have malabsorption and you know, starve and not get their food. So we got to be careful about that. So you want to take your enzymes if you actually have exocrine insufficiency and treat that part. What we don't know is if that reduces risk of diabetes or in any way improves insulin secretion. That's sort of that part that's a little bit uncertain or controversial about the incretin hormones and how they play into diabetes. There are studies that suggest if you have malabsorption, your GLP-1 and GIP levels are lower because your absorption of food is kind of signaling that release of those gut hormones. But then the evidence on whether doing the enzyme therapy helps with insulin secretion and blood sugar control, that's the part that isn't as well known, isn't as clear.
We have a couple of questions from people about whether there is a connection with COVID. Two people who have had EPI and pre-diabetes or a pancreatitis attack after having COVID. Is there an association?
Okay, well, let me say I'm not a COVID researcher, so I can't give you 100% the answer on this. We certainly have seen some individuals. There has been some question of whether there could be some pancreatitis precipitated by COVID. I mean, certainly have been people who get pancreatitis after COVID. That's not in doubt. Now, whether that is because the COVID triggered it or just sort of a bad timing of things or something else going on, I think is a little bit less certain. But I do recall there were some studies early on with actual viral loads in the pancreas tissue. So there may be something there. And there was also some question of COVID triggering diabetes as well. So there may be some relationship with pancreas disease, but I have to say I don't do a lot of research directly in that area, so I may not have the most up-to-date data on that.
Right. And I think there are 3 questions about diabetes post TPIAT. There's one who's had a lot of big islet yield, but the blood glucose shoots up and then down.
Sure. Yep.
And another question about how long can we expect the islet transplant to last from some young man who's doing well with it. I think that's it.
Okay. So I'll tackle those two. So I'm assuming not everyone on here, obviously not everyone on here has had TPIAT, and maybe not everyone on here knows about it, or maybe they do. But so let me just take one step back from the actual questions and just put it in context. So for some people who have advanced pancreatitis where it's really disabling and sort of treating it symptomatically is no longer an appropriate option, they'll have their pancreas surgically resected. So that's the total pancreatectomy part. We'll do a special process that extracts the islets out of there. The islets are infused in the liver. That's the islet auto transplant part. And some individuals will come all the way off insulin therapy after that surgery, whereas others will continue to need insulin. So the goal is we're trying to replace those islets or save those islets out of the pancreas, but we do lose some in the transplant process. So what we see is that people who come off insulin therapy, I will say we have seen people who are as far out as 22 years off insulin. So can they last a long time? Yes, they can. Is that the norm? No, it's not. And we tell everyone we think at some point they're going to be back on insulin in their lifespan, because if we follow people long enough, they eventually go back on insulin. More typical might be 3 to 5 years off insulin, some people being off 10 or 15 years. And actually, we have a study going on now. We call it the LIFT study, where we're looking at people who are 5 to 20 years out to better understand this. Like, how often are we seeing islets survive long term? What does that mean for glycemic control? What are the factors that cause islets to fail or persist? We think some of those things that go into the islets not working longer over time might be sort of stress on the islets. So we try to monitor blood sugars, even people off insulin, to make sure they're well controlled. So this gets into this question. So that's kind of about the islet attrition part. And then this question about sort of irregular blood sugars when you have islets that seemingly are a large number of islets that seemingly are functioning functioning well, in the sense that you can get off insulin therapy and yet you have these kind of weird highs and lows. And what is that? It's complicated. I'll say upfront. So, and we don't understand all of that. That's another thing we're actually looking at right now. But some of it is the fact that we actually remove part of the intestine with the TPIAT surgery, the part that's wrapped around the pancreas, and have to reroute the plumbing. That actually changes those GLP-1 and incretin hormones I was talking about, and can actually, so we see this actually in people who have gastric bypass surgeries and other surgeries that don't touch the pancreas at all, that they can get some of these highs, like early highs and then lows, just from the gut rerouting. So some of this is actually the gut surgery part. And some of this is probably the islet part. So in addition to the gut surgery part, if islets are a little slow, like if they're a little stressed at their capacity, they're not all rested with a bunch of insulin formed and ready to go when you eat a meal. So they take longer to kick in. Like they have to see that high blood sugar to kick in, rather than kicking in right away when you eat, like a healthy pancreas does. So sometimes you just get some delay in islet function, and then that can kind of overshoot a little bit. You drop down too low, and then the glucagon part may not respond normally. So as you're shooting down low, you should have this other hormone, glucagon, that's going up to counter your insulin, and it's not. And so this is where you get, so all of these things, the guts, the islet, all of it kind of can get this like highs and lows for some people, even if they're off insulin.
Great, thank you. A couple questions about treatment. Insulin pump versus injections, what do you recommend? And is one insulin better than another? And how do you deal with morning highs?
Oh, these are such great questions. So insulin injections versus pumps, it really depends. There are some people who do, number one, there are some people who do really well on just a low dose of like basal insulin injected. And for them, oftentimes the simplest and easiest thing is just to do insulin injections and not switch to a pump. So for some people, insulin injections are the right thing. I also do have people I think would do well on a pump, and that is just like, wow, technology management, no thank you. Like, give me the simple like insulin injections that I completely control and are sort of, you know, I guess the book, like the textbook versus an iPad, right? Just like sort of, some people are more or less, you know, receptive to sort of computer technology. But insulin pumps work really, really well for people who are needing multiple daily injections, for people who are very insulin sensitive, or small kids, where you might need really tiny increments of dosing in insulin. Because the one thing we can do with insulin pens is full units, or sometimes half units for our dosing. But with pumps, we can do like 1/10 of a unit or 100th of a unit. So what I mean by that is, like, if you're injecting with a pen, you might have to choose between 1 unit or 2 units. But if you have a pump, you might be able to get 1.25 units, right? So there's this precision that comes with pumps. And then pumps for some people can also talk to the continuous glucose monitors and do some automatic regulation. People will call this artificial pancreas technology, closed loop pump technology, automated insulin delivery, another example of a thing that has lots of names. So for some people who have very little insulin secretion, having that type of regulation where the pump talks to the sensor is a really good thing, and pumps are better for them. So that's kind of pumps versus injections. I'm not going to say one is right or wrong, but for various people, a pump or injections might be, you know, one or the other might be better for them. And then this question of morning highs. So there's a number of different reasons why that can happen. So I can't say specifically why that person is seeing that, but one of the things that actually does happen physiologically for most of us is that our cortisol that our body makes is in a circadian type of rhythm. And so it rises overnight and peaks in the morning and is lowest actually late in the afternoon and evening. And so this sort of rise in cortisol, because cortisol raises blood sugars, can affect the overnight blood sugar and the morning blood sugar. So for some people, that morning high can be because of this sort of cortisol effect. There can be other reasons for it too. how to deal with that. So this is actually one of the places where, if that's the case, that someone just needs more insulin in that kind of overnight and early morning period, a pump might be a better option for that sometimes, because you can set different amounts of insulin delivery at different times of the day. Whereas if you're taking something like Lantus, it's just one set dose, right? Or you could do it twice a day, but it's still kind of on board for a long time. You can't titrate it as well for different time periods of the day. In terms of that question about insulin, different types of insulin, like different brands, for most people, there's sort of long-acting insulin and rapid-acting insulin, and what the brand doesn't matter much. Most of the time, the brand doesn't matter much. Some of those long-acting insulins, some of them are a little bit long-acting than others. So for some people, they'll react better to one of the long-acting insulins than the other. And every once in a while, someone is better responsive to a certain rapid-acting insulin than another. So mostly interchangeable, but not entirely interchangeable.
Thank you. This is fantastic. We are almost at the end of our time. Olivia has an important announcement, but Dr. Bellin, thank you so much. And everybody, thank you for your questions. We got most of them, but if you had a question that wasn't specific to diabetes or we didn't get to you, we will try to follow up with an email. You see here on the screen, info@missioncure.org. Please feel free to email us. We don't have everybody's email with their question on the webinar, so please feel free to email us there and we will respond. Olivia, over to you.
Thank you, Megan, and thank you everyone for joining us today. On behalf of the Mission Care team, I extend our sincere gratitude and appreciation to Dr. Bellin for her time, effort, and support in making this webinar possible. And thank you, Shruti, for sharing part of your health journey with us. It was a pleasure hearing from both of you. We post resources for our patient community as part of our patient education program, so please subscribe to our newsletter on our website and follow our social media handles to learn more. We invite you to complete a quick 1-minute survey that will automatically pop up on your browser after the webinar and is also in the chat. Your responses will help us create the resources you need and value. Registered people will also receive a recording of this webinar, which we will upload to our website tomorrow. Our virtual door is always open, so if you have any questions or feedback, just let us know. Thank you again, everyone, and we hope you have a great day.